Which one is that? I have to go to the bill.
You have a motion and a second, Assemblymember Gomez.
It's a good bill. We're working through a couple of issues with the opposition, but they have my word that I'm going to continue working on it, and I can talk to the chair of the next committee to make sure that it's done before it gets out.
Thank you for your commitment. I heard that's an excellent chair who will work with you very well. Witnesses in support?
Good afternoon, members. Christina Romero with Planned Parenthood Affiliates of California, representing over 115 health centers. In the interest of time, I'll be very brief. We feel that it's imperative that this bill is passed so that hospital transfer agreements are not at the whims of DPH or a hospital who has a moral objection to a clinic opening in a community. I ask for your aye vote.
Thank you.
Sean South on behalf of the Primary Care Association in support.
Deborah Rotenberg, legal counsel with Planned Parenthood Affiliates of California, here to answer any technical questions.
Thank you, Assemblymember Burke, joint author.
Burke in support.
Excellent. Additional witnesses in support.
Claudia Estrada Powell, Planned Parenthood Los Angeles in support.
Thank you. Additional witnesses in support. Witnesses in opposition. Can we make sure we have space for the witnesses in opposition?
Mr. Chair, members, Tim Madden, representing the California chapter of the American College of Emergency Physicians. We have an opposed unless amended position. We believe there is real value in having a written transfer agreement established between clinics and hospitals. It provides real information when someone's coming into the emergency department as to extent of their condition. With that being said, we've had good conversations with the author's office and with the sponsor, and as indicated by the author, we look forward to continuing those conversations.
Additional witnesses in opposition.
Yes, Mr. Chairman and members, I'm Janelle Trevathan. I have just asked the Sergeant at Arms to distribute two things to you. One is a letter from a lady down in Southern California, and the other is a copy of Title 22, Chapter 5, as it currently stands, as opposed to what is written into the analysis. Although AB 1177 would repeal the current transfer agreement regulations for all primary care clinics, the accompanying analysis clearly shows that AB 1177 is in fact meant principally to make sure abortion clinics, including those that perform abortions well into the second trimester, don't have to provide this safety net for women. And the supporters of this bill are willing to lower the standard of care for all clinics, including birthing clinics, in the process. Just how far is this legislature willing to go to put women's health and safety at risk? 2 years ago, Assembly Bill 154 and Assembly Bill 980 lowered the standard of care for women obtaining abortions in California by allowing clinicians who do not have the training of medical doctors to perform first trimester abortions, and by completely eliminating all standards for abortion services in Article 5 of Chapter 7, Division 5 of Title 22 regulations. The analysis you have received for AB 1177 incorrectly advises you that existing state regulations require primary care clinics that perform abortions to have certain important equipment and supplies available, and that only a physician will perform abortions at a primary clinic. Those non-existent regulations are noted in items 1 and 2 under existing state regulation in the analysis. Along with all other standards in Article 5 of Title 22, these regulations were repealed as of July 1st, 2014 by Assembly Bill 980. I have copies of Assembly Bill 980 if you really want to see it, but it's in there. And what you received is what has been eliminated completely regarding abortion regulations. If you vote for this bill and think there are plenty of regulations in place to protect women, you are mistaken. Now, the authors of AB 1177 propose to undo another important safety net for women obtaining abortions at primary care clinics. If this bill passes, a woman would no longer be guaranteed prompt and adequate emergency care should it be necessary. What woman, knowing that yet another regulation providing for her safety has been eliminated, would want to trust her life to a primary care clinic? I urge you to vote no on 1177, one more threat to women's health and safety that should not be tolerated in California.
Additional witnesses in opposition, please state only your name, organization, and position.
I thought there was 2 minutes.
Your first two witnesses used your time. Name, organization, and position? Anyone in opposition?
Yeah, prenatal murder opponents.
Okay. Anyone else? Anyone else in opposition? Seeing none, any questions or comments from committee members? Seeing none. Assemblymember Gomez, would you like to close?
Thank you, Mr. Chair. Thank you for your due pass recommendation. Also, I'd like to point out that the California Hospital Association is neutral on the bill.
Thank you, Mr. Chair. We have a motion. The committee can entertain a motion. We have a motion. We have a second. The motion is due pass to appropriations. Madam Secretary, please call the roll.
Bonta?
Aye.
Bonta, aye. Mainshine? Bonilla? Bonilla, aye. Burke? Burke, aye. Chavez? Chavez, no. Chu? Chu, aye. Gomez? Gomez, aye. Gonzalez? Gonzalez, aye. Hernandez? Lackey? Nazarian? Nazarian, aye. Patterson? Patterson, no. Ridley Thomas? Ridley Thomas, aye. Rodriguez?
Aye.
Rodriguez, aye. Santiago? Santiago, aye. Steinnorth? Steinnorth, no. Thurmond? Thurmond, aye. Waldron? Wood? Wood, aye.
The bill passes 12-3. Next, we have Assemblymember Bonilla, item number 6, AB 486. This bill enjoys support. Assemblymember Bonilla. We have a motion and a second.
Thank you. It's very straightforward. There was a bill a few years ago by Jose Solario. Unfortunately, technology didn't catch up with the aspirations of the bill, putting hospitals in a position where they can't put all the information they need to on the barcode. They need to be able to also write it out in readable form. And this bill rectifies the error by allowing data to be included on the medication label via a barcode or in human readable form. I have you want to give testimony?
Mark Weideman, on behalf of the California Society of Health System Pharmacists. We're the sponsors of the bill. We're working with the Board of Pharmacy on this. This is a technicality that needs to be fixed here. The Board of Pharmacy has been granting waivers so that hospital systems can comply with this current barcoding rule. This would allow them to no longer have to grant waivers. It would be fixed in statute with Assemblymember Bonilla's bill. We strongly support. Thank you.
Thank you. Ask for your aye vote.
Additional witnesses in support?
Tanya Robinson Taylor on behalf of the California Hospital Association in support.
Michael Toe with Providence Health and Services in support.
Megan Maddox with the California Pharmacists Association in support.
David Gonzalez on behalf of CAPG in support.
Julie Broyles on behalf of the California Association of Joint Powers in support.
Witnesses in opposition? Seeing none. Questions or comments from committee members? Seeing none, we have a motion and a second. Assemblymember Bonilla, would you like to close?
Just ask for your aye vote.
Thank you. The motion is due pass to Business and Professions Committee. Madam Secretary, please call the roll.
Bonta?
Aye.
Bonta, aye. Mainshine? Bonilla?
Oh, aye.
Bonilla, aye. Burke? Aye. Burke, aye. Chavez? Aye. Chavez, aye. Chu? Aye. Chu, aye. Gomez? Aye. Gomez, aye. Gonzalez? Aye. Gonzalez, aye. Hernandez? Lackey? Nazarian? Aye. Nazarian, aye. Patterson? Patterson, aye. Ridley Thomas? Aye. Ridley Thomas, aye. Rodriguez? Aye. Rodriguez, aye. Santiago? Aye. Santiago, aye. Steinnorth? Steinnorth, aye. Thurmond? Aye. Thurmond, aye. Waldron? Wood? Aye. Wood, aye.
bill passes 15-0. Next, we have item number 7, AB 521, Assemblymember Nazarian. We have a motion. We have a second.
Thank you. And I'd want to keep my comments short, but I think I need to get into it just a bit. Mr. Chair and members, I accept the committee's suggested amendment. Thank you and your staff for your very hard work on this bill. Approximately 16% of Californians who are HIV positive do not know they are HIV positive, so they are not receiving treatment, and they are inadvertently exposing others. This percentage rises to 58% for individuals up to the age of 24. 20,000 Californians who do not know they are HIV positive are causing 70% of the new infections. In attempt to find these individuals, this bill requires hospital emergency departments only if blood is drawn from a patient to offer to test for HIV. This bill does not mandate across-the-board testing. AB 521 simply requires the test to be offered and requires the patient to consent to the testing. If the patient does not consent, then no testing will be administered. AB 521 is consistent with CDC's recommendation that routine HIV testing occur in all health care settings, including emergency departments. Furthermore, existing law requires insurance companies to cover the cost of an HIV test in an emergency room, even if the test is unrelated to the primary diagnosis. Medi-Cal also covers the cost of HIV test in an emergency department. Despite these efforts, HIV testing occurs in emergency departments only when the patient affirmatively seeks an HIV test. AB 521 addresses an issue raised by national studies which have demonstrated that HIV testing is not routine in the settings where there is greater opportunity to engage large numbers of patients who might not access care in any other healthcare venue. I understand the concerns and appreciate the opposition's willingness to engage in a dialogue. I have taken an amendment to help alleviate some of the concerns. April 14th amended version of the bill states that an emergency department is deemed to be in compliance with the counseling required if they provide printed materials to the patient. The printed materials must include the information required by existing law on treatment options available. And with that, I thank you and respectfully ask for an aye vote. And with me is Rand Martin on behalf of the sponsor of the bill, AIDS Healthcare Foundation. Thank you.
Mr. Chair and members, Rand Martin on behalf of the AIDS Healthcare Foundation. I appreciate the summary that Mr. Nazarian has provided. He actually took half my testimony away from me. But one statistic I do want to point out that that he did not include is the fact that despite the fact that we believe that if you read the press, that we have control of this epidemic, there are still 5,000 new infections in California alone every single year. That really does indicate that we are far from in control of this epidemic. And the reason we're not is because there are populations that are increasingly hard to get to. AHF happens to be the largest provider, as I indicated in testimony on another bill, but we're also the largest tester in the state of California. We did 50,000 tests last year. We did 3 million tests worldwide last year. So we know the experience that testing provides, and testing is the answer to controlling the epidemic. Research demonstrates that if people know that they're HIV positive, they will change their behaviors and they will voluntarily access care and treatment. So if we can get people tested, if we can get them into places where testing occurs, we know that will happen. We test in a lot of different places. We even have mobile vans that go out to Target shopping centers and down the street from dance clubs at 3 o'clock in the morning. But the last major institution where testing is not routinely happening is the emergency department. And we all know that emergency departments are melting pots when it comes to the types of clientele that attend an emergency department. We're very sympathetic to the burdens on emergency departments. We have done everything we possibly can, short of dropping the bill altogether, to try and eliminate as much of the burden as we possibly can so that it is a far more routine and far less burdensome effort in the emergency department. We think it's important to get ahead of this epidemic. We think this is a really good way of doing that, and we ask for your support today.
We have a motion and a second. Any further witnesses in support? Seeing none. Witnesses in opposition?
Mr. Chair, members, Tim Madden, representing the California chapter of the American College of Emergency Physicians. And before we start, I just want to take the time to thank Mr. Nazarian, and we've met with him a number of times along with the sponsors, AIDS Healthcare Foundation. This is a tough one. We're very sympathetic to the goals that are trying to be accomplished here. It really comes down to the appropriateness of the location. For emergency departments, it's our mission to treat people with emergency medical conditions, and that's not what this is about. We're very sympathetic to what the member is achieving. We want to thank him for his time. We remain opposed, and with me I have Amy Mullen, an emergency physician from UC Davis, to elaborate on some of our concerns.
Thank you. I'm an emergency physician. I'm speaking on behalf of the California American College of Emergency Physicians. Requiring HIV testing from every patient in the emergency department who has a blood draw is impractical and unworkable. It will slow down the care of emergency department patients and grind emergency care to a halt. Research shows from a test at San Francisco General the prevalence of undiagnosed HIV, if you test all patients, is low, less than 1%. This is important because it increases the risk of false positives. So before you vote on this bill, I want you to consider for a minute what this means as an emergency provider. A patient comes in that I'm trying to treat for a heart attack or a stroke. I now have to figure out if that person has had a test within the past 12 months without access to their primary care records or their records from another ER. We have to have that conversation about HIV testing, all while I'm trying to provide timely care to that patient for their heart attack or stroke. We then, if my department has access to rapid HIV testing, which would be back in the course of that ER visit, sit down and have another conversation with that patient about their results. Best case scenario, this takes 5 minutes. I see 20 to 30 patients per shift. Adding an additional 5 minutes is another 2 hours that patients are waiting in the waiting room. In follow-up, let's say my department does not have rapid HIV testing, and that result comes back 2 to 3 days later. Then I come on to my next shift, and I need to spend another hour or two contacting the 20 to 30 patients I saw the day before. I understand the goal of increasing HIV testing, but the consequence for the delays in care that it will cause to our emergency care system are just not worth the risk. Thank you.
Additional witnesses in opposition?
I'm Senior Vice President, Chief Medical Officer for the California Hospital Association. I want to thank Mr. Nazarian for willing to work with us on language and also understand the goals of this bill. What we are concerned about is that I concur with what has just been said from our emergency room physician colleague, but I think you have to take in consideration what the Affordable Care Act said, and there is a triple aim. The first triple aim was to have a patient experience, which she talked about will increase the length of time in the ED. The second thing is that we must have a population health management. This does do that, but the question is if this is in the appropriate place with the appropriate cost. This will increase costs. It's an unfunded mandate, and for that reason, the California Hospital Association opposes this bill. Thank you.
Stuart Thompson on behalf of the California Medical Association. I'll be brief, and I'd like to echo the previous comments. While we're generally supportive of increased HIV testing and counseling, for this bill, we are concerned about the strained resources or the strain it'll have on emergency room resources. Just to put simply, we don't think that the emergency room is the appropriate place for a mandated public health screening, and for that reason, we are opposed. Thank you.
Mr. Chair, would you like me to respond to some of the questions raised?
I think if the members have questions or you feel super compelled to, of course you may, that's your prerogative. But let's go to member questions, and maybe someone will come up with the questions that you can play cleanup at the end if there's anything outstanding. Dr. Wood.
Yeah, and one of the questions I have, and this is regarding consent. I mean, if I missed it, I apologize. It's late. I could have missed a lot of things. But the whole concept that someone might come in unconscious, maybe unable to give permission for consent, how do you deal with that? Because this isn't a new conversation. We've had this conversation already. So If I missed it somewhere, I apologize. But
No, I apologize. I don't think I mentioned it, but we did take a amendment, and I was going to address one of the other concerns that came up. The patient has to be conscious in order for them to approve. If they're not, then they won't be. Yeah, they need to be capable of giving a consent.
Okay. All right. Thanks.
Mr. Bonds.
Assemblymember Ridley Thomas.
Mr. Nazarian, I know that you have the strong interest of the people of Los Angeles at heart. We have a significant population in the African American community that's affected by this disease. The many things have improved. However, as one who sits on this committee and our focus is public health, there's no reason that I could find to not support this bill. There may be lingering concerns with the emergency rooms and with facilities and the like, but for public health, this bill should move forward. I already moved the bill. Thank you for bringing it forward, and I know our constituents appreciate your leadership on it.
Additional comments from members. Assemblymember Waldron.
Thank you, Mr. Chair. I'll be supporting the bill today, but I do have the concern what the emergency room physician was saying, because, I mean, I would assume, maybe this is just an assumption on my part, that someone comes in for an emergency, they're going to be treated for the emergency, and then afterwards, upon discharge, would be given the test if they say yes. I mean, I would assume that's how it would be. It wouldn't interfere with any of the ongoing,
So I'll start and I'll hand that off. But basically, half of the individuals that come to emergency room end up even having the blood drawn, if need be. And of that portion, then many people don't even give consent. Or in certain cases, someone may not be conscious, or someone may be in an inebriated state, or whatever the state might be. So it's not as though the fraction, based on the fraction, it gets to a very small group of people. And the idea of this bill was to be able to have yet one more forum of getting that potentially 3 to 5% undetected infected individuals to be identified. It was just to be able to capture a certain small group. So,
and Ms. Waldron, I'd simply like to add that we've been very careful in this bill not to be prescriptive. We set the overarching policy, but it's up to the hospital to figure out how best to do that. And I think that the first thing that they will do is make sure that the emergency is taken care of first. We're not telling them that they have to do anything in one order or another.
I understand.
Sorry, let's go to Assemblymember Chavez, then we'll go to the witness in opposition.
I'm listening to discussion. I had an open mind, and I'm trying to figure out what are we trying to accomplish here for the percents. If I'm hearing what the doctors are saying, it's less than 1% of the people coming through would even fall within this area, but you're saying you're trying to find 3% of a population. I'm thinking, what type of numbers are we actually talking about that we're going to establish a new procedure in the ER? What's your intent, I guess, the maker of the bill? How many people, what are we trying to do in numbers?
In numbers from what I understand, there are potentially up between 3 to 5% of individuals who come to an emergency room that could be found, and if I'm wrong, please correct me, that could be found from their blood drawn that they might be HIV infected.
So 3 to 5% that could be?
Yes.
So 3% of a could be population?
Between 3 and 5%.
Could I have the professionals now tell me what are we talking about? What percent are we trying to do?
You know, we might be talking apples and oranges, so I'll just draw from the analysis that the committee put together, and it says there are 20,000 people in California who do not know that they're HIV positive.
20,000 out of 39 million.
Correct.
There was a study in the Journal of Public Health in 2009 or 2008, I don't remember exactly, but I could send it to you, where they screened patients at San Francisco General Hospital. And the prevalence of undiagnosed HIV, so the percentage of people who did not know that they had HIV, who tested positive for HIV, was less than 1% in that study. So that is why I quoted that number, because it's actually looking at relatively high-risk HIV patients in an emergency department.
In a rural, in a highly urban center?
Yes.
San Francisco?
San Francisco General.
Okay, thank you.
Mr. Chair, if you don't mind, I do want to point out, I appreciate the study, and the study is helpful. The study is also in an environment in which HIV testing is very, very prevalent. There's a lot of testing that goes on in San Francisco, so finding smaller numbers in San Francisco is not surprising. The research and the statistics that the Department of Public Health has on HIV indicate that some of the worst places are places that are less urban. The more rural areas, the other urban centers that are not in San Francisco or Los Angeles are actually seeing higher numbers of people who are testing late for HIV. They're already coming down with symptoms of AIDS before they even get an HIV test. And it's those populations that we really need to get to. And the other population, as Mr. Ridley Thomas has pointed out, even in an urban center like Los Angeles, a lot of communities of color are at very high risk, are not engaged in health care, and they find the place to get all their health care is still in the emergency department. Very important to get to those people as well.
Additional member comments or questions? Assemblymember Gonzalez.
And I've heard a little bit, but I haven't found a specific number. You talked about the rapid test and the false positives. Do we know what the difference is in false positives? I'm more worried about, and thank you to the, I know I'm probably going to vote for this because I know this author is committed to continue to work on it, but I have really strong reservations about the place that we're putting emergency room doctors and patients in. So I was just wondering on the false positive, on the rapid test, what is the difference?
So the difference is the rapid HIV test is a preliminary result. They'll actually run a Western blot, which is a confirmatory test, but that takes usually 2 to 3 days. So if you have a positive result on the preliminary test, you would run the confirmatory test. The problem is if you start testing populations where there's a lower prevalence, so the disease is less likely, the likelihood that your positive result is a false positive is higher. Does that make sense? So the lower the prevalence, the higher your rate of false positive results. And so that is one of the other problems, is that I could have a patient, not my primary care patient, that I don't have a relationship with, that I then have to say, hey, you have this preliminary positive result. I know you came here for a heart attack, but now I have to tell you you have this preliminary positive result. And I'm going to run a confirmatory test and then try and contact you 3 days later, even though you're not my primary care patient. You could be from out of town. You could be hard to contact. And so that puts us in a really hard position. And from the timing perspective, because I think, this is something that functions really well in a clinic or an outpatient setting. If I treat the emergency first, the acute stroke or the acute heart attack, and then say, hey, let's talk about HIV testing, I've completely spent another 2-3 hours for that ER visit, and that's a patient in the waiting room who has to sit there for another 2-3 hours. And that's the person that it's not fair to.
And then one more question to the author, if possible. I see in the bill that the hospital can charge the patient. What happens, and I know Medi-Cal will pay for this, but undocumented immigrants still use emergency room care as the primary source of their health care. Have we considered is there a funding source? I mean, we also have a population that probably doesn't get tested for HIV at the rates that they should be. Is there a funding source, or are we just saying, hey, if you're willing to pay for it out of pocket, you can have this test as well?
Sure. There is always going to be a population that uses emergency rooms that does not have any coverage, and we appreciate that. And I think that we can continue to work on that issue. Medi-Cal, Medicare, and private health now cover HIV testing in the hospital emergency department. There are funds available through the Office of AIDS to pay, and through county health departments to pay for testing for people who do not have coverage anywhere else, those are funds that hospital emergency departments could take advantage of as well. So we can continue to close that gap so that almost everybody who walks through can pay. And yeah, there are people who can be private pay as well. The cost of the test is actually not that much. It's less than $40. I'm not sure what the hospitals might add to that, but the cost of the test is actually pretty small for those who could do private pay. I also want to make one other point relative to the testing sensitivity. The rapid HIV test is 99.7% sensitive, which means that 99.7% it's right. So yeah, there are false positives, but they are very, very small numbers. And yes, that's why we do confirmatory testing, but very few confirmatory tests will change the outcome of the initial test result.
Okay, thank you. We have a motion. We have a second. I just want to thank you, Assemblymember Nazarian, for authoring this important bill and bringing it before the Health Committee today. I'll be supporting the bill today as proposed to be amended. And this bill will let us reach the final 16% of California's HIV-positive population who are unaware of their status and cause 70% of new infections. There are some important arguments that have been made by the opposition, and we're at the beginning of a long process here, so I encourage you to work with the opposition to try to accommodate some of their concerns and see if you can improve the bill. But with that, we have a motion and a second. Would you like to close, Assemblymember Nazarian?
Ask for a vote respectfully. Thank you.
The motion is due pass as amended to appropriations. Madam Secretary, please call the roll.
Bonta?
Aye.
Bonta, aye. Mainshine? Mainshine, no. Bonilla? Burke? Burke, aye. Chavez? No. Chavez, no. Chu? Gomez? Gomez, aye. Gonzalez? Gonzalez, aye. Hernandez? Hernandez, aye. Lackey? Nazarian? Nazarian, aye. Patterson? Patterson, no. Ridley Thomas? Ridley Thomas, aye. Rodriguez? Rodriguez, aye. Santiago? Santiago, aye. Steinnorth? Steinnorth, no. Thurmond? Thurmond, aye. Waldron? Waldron, aye. Wood?
176. Your bill is out at a vote of 11 to 4.
Next up is Mr. Chairman Bonta, item 2, AB 176. You have several